In this session, we will talk about the individual amino acid. The first we are talking is phenylalanine. When it comes to phenylalanine, we know that the mnemonic that we have used, the fan in the name is going to be aromatic, and the amino acid starts with the letter P is going to be essential because the mnemonic was TV till 9 PMH. So P, it is essential. Second, because fan in the name, so it is going to be aromatic, and all the aromatic are water insolubles. Now, we know that tyrosine is a non-essential amino acid. The reason being, from phenylalanine, we can make tyrosine. So, the phenylalanine can be converted into tyrosine with the help of two enzymes. One is the phenylalanine hydroxylase and second is BH2 reductase. If these two enzymes are there, we can convert the phenylalanine to tyrosine. But sometimes what happens is that there can be deficiency of either of the enzyme. Maybe the phenylalanine hydroxylase or the BH2 reductase. If there is deficiency of any of one, the reaction will not happen. And if this not happen, the tyrosine will not be formed. And the phenylalanine is going to accumulate in the body. The phenylalanine will convert into its ketone version, and these ketone versions will start coming in the urine. And this disease will be referred as phenylketonuria. If this phenylketonuria is due to deficiency of phenylalanine hydroxylase, that is called as phenylketonuria type 1. And if it is due to deficiency of BH2 reductase, it is called as type 2. Now, when it comes to the ketone version of the phenylalanine, the ketone bodies that we are going to make is phenylacetate, phenylactate, and phenylpyruvate. Out of that, the phenylacetate molecule, it has a very bad smell. It smells like mouse. So the patient will have the mousy smell of the urine. In fact, the mother will say that when she is changing the diaper, there is very bad smell in the urine of the child. And secondly, these ketone versions, particularly the phenylpyruvate, can lead to damage to the neurons, will lead to mental retardation in the baby. Then one more thing that is going to happen is if the tyrosine is less, we know that from tyrosine we make melanin. The skin color is decided by melanin. So this patient is having decrease in the tyrosine, so decrease in the melanin, and ultimately because melanin is less, so the child will have relatively fair complexion. But this patient will not have the problem on day 0 of the life. The reason is when the child is there in the fetal life, the phenylalanine is supposed to convert into tyrosine. But this fetus is unable to make the enzyme, but the maternal enzymes are there to do the things. So during the fetal life, there is no problem. Even the child is not having the enzymes, the reaction will happen. The maternal enzymes will do the job. But once the birth has done, now after 72 hours, these enzymes will start washing out. And now the fetus is, the child has to make its own these enzymes. But the child is unable to produce these enzymes, so phenylalanine now cannot convert into tyrosine, and that will start accumulating and the symptoms will start appearing. So one important point they ask is, the child is going to have normal at birth, there is no symptom. The symptoms will develop after 3 to 4 days of life. There will be bad smell of the urine, and slowly the mental retardation will start happening, and it is going to be a profound mental retardation that is going to be there. And the child will have relatively fair complexion. To diagnose this, we can do some fancy tests such as Guthrie test or the heel prick test. But these tests has to be done after 72 hours of birth. The investigation of choice is going to be the tandem mass spectrometry. We can do the ferric chloride test, but that is a non-specific test that detects the phenylpyruvate, and it is a non-specific test. Then how we are going to treat this child? We have to explain to the parents that your child is unable to metabolize phenylalanine, so we have to give phenylalanine free diet. Plus, normally the phenylalanine can convert into tyrosine in our body, but this child is unable to make the tyrosine, so we need to give the tyrosine supplements. So the patient has to reduce the phenylalanine in the diet, and we need to increase the tyrosine in the diet. So this is all from the individual amino acid phenylalanine. The next individual amino acid is tyrosine. See, again tyrosine, tire, because the smell, if you remember the mnemonic, so tire, it is going to be aromatic. It is water insoluble, and this is one of the amino acid which starts with the letter T but is non-essential, that is tyrosine. And why it is tyrosine? Just now I told you that we can make it from phenylalanine, so it is non-essential. Now, if we want to detect tyrosine or histidine in any given solution, we can do a test called as Pauli test. Pauli test, where we use the reagent sulfanic acid. Tyrosine is used to make 3 special products in our body. One, it is going to make the melanin molecule which decides the color of the skin. Second, it is going to make the T3, T4, and the third is the catecholamines. Catecholamine, for example, the norepinephrine, epinephrine, dopamine, they are going to be made by tyrosine. So tyrosine is making 3 special molecules: melanin, T3, T4, and the catecholamines. We are going to discuss them one by one, how they are going to be formed. Starting with the first one, melanin. When it comes to tyrosine to melanin, the rate limiting enzyme is going to be tyrosinase. And we require the cofactor copper. By any chance, if this tyrosinase enzyme is not there, the reaction will not happen. And if this reaction will not happen, the tyrosine will not be able to convert into melanin. And the child will have severe deficiency of melanin. Absolute deficiency of melanin can be there. So the point is, if there is deficiency of tyrosinase, the melanin will be almost not there. The patient will have a complete fair complexion, and that is called as albinism. This is the first special product, that is melanin. Now coming to the second special product, that is thyroid hormone T3, T4. See, in the thyroid, we have the thyroid follicles. Thyroid follicles, basically, if you see this particular structure, this is the thyroid follicle. If I just zoom out in this area, what I will be noticing is there are actually this particular structure will come out. If I zoom in this area, I will be able to see this particular structure, which is having three things. One, the outermost is the blood capillaries, then these cells, which are the follicular cells, and inside that there is a liquid called as colloid. To further understand this, if I take a small section out of these thyroid follicles and I just zoom in this area and I make a bigger diagram to understand that how these thyroid follicles works and how they make the thyroid hormone. So what I will notice is, this is the structure. The outermost is the blood capillary, then is the follicular cell, and the innermost is the colloid. Whatever dietary iodine which you are taking, the iodine will get absorbed. The iodine comes in the blood. Now the iodine is supposed to enter in the follicular cell via the sodium iodine channel. The sodium iodine channel is going to be opened via the TSH coming from the anterior pituitary. The iodine molecules now will start coming in the follicular cells. The follicular cells are going to pump these iodine molecules forward via the pendrin channels, and now the iodine molecules will come in the colloid. The iodine molecules, once they come in the colloid, there will be couple formation of these iodine molecules, which are called as iodide. And to make the couple, we require the enzyme TPO, thyroid peroxidase. Now, meanwhile, when all these processes was happening, the thyroglobin protein was synthesized in the follicular cells, and this thyroglobin protein contains a lot of tyrosine. So now this thyroglobin protein comes in the colloid, and the iodine molecules which were synthesized, now these iodide molecules will start attaching on this tyrosine molecule. There will be one iodide molecule will attach, and this unit is called as monoiodotyrosine, and it is possible that two iodide molecules will attach, and now this is called as diiodotyrosine. So MIT and DIT, a lot of MIT and DIT will be formed in the colloid. Now these MIT and DIT, they will be pumped back in the follicular cell, and here they will join together. If MIT will join with the DIT, mono plus di will make the T3, and if DIT and DIT will join together, that is going to make the T4. And that is the major hormone that is synthesized in the thyroid gland, the T4. Now this T4 will come out from the follicular cell and it will come in the blood. And this T4 is roaming in our body. And the good thing is, this is inactive hormone, because every tissue requires the thyroid hormone, and this inactive hormone is going to roam around in our body here and there. Whichever tissue wants the thyroid hormone, they will take the T4, which is in the inactive form, that will be converted in the active form by the peripheral tissue itself. So now this T4 molecule is roaming around, and in the peripheral tissue it will be converted into T3 with the help of enzyme 5-deiodinase. And for this process we require selenium also. So this is how we actually make the thyroid hormone. And what is the clinical correlation is, one, to make the thyroid hormone we require a special protein called as pendrin, which is pumping the iodine molecules. This pendrin is actually found in two places. One is the thyroid gland and second is the ear. By any chance, if this pendrin channel is not working, neither the thyroid nor the ear will work. So the child will have congenital hypothyroid plus sensorineural hearing loss, and that is called as the pendrin syndrome. So if you ever come across MCQ where they are saying about the congenital hypothyroid plus sensorineural hearing loss, they are talking about the pendrin syndrome. The pendrin channels are not working. The third and the last special product, that is the catecholamines. When it comes to catecholamine, there are three catecholamines. We are going to discuss: dopamine, norepinephrine, and epinephrine. The tyrosine, when it converts into the catecholamine, first it will convert into dopa, then it will convert into dopamine, then it will convert into norepinephrine, and ultimately epinephrine. To do the catecholamine synthesis, the rate limiting enzyme is going to be tyrosine hydroxylase. tyrosine hydroxylase. And this is how we are going to make these 3 catecholamines. When they are going to be further broken down, when they are going to be catabolized, the dopamine will convert into something called as homovanillic acid with the help of the enzyme COMT and MAO-B. The norepinephrine can convert into normetanephrine, and ultimately that can come in the urine. The epinephrine can convert into metanephrine, and that can come into urine. In fact, this metanephrine can convert into vanillyl mandelic acid, VMA, and that VMA can also come in the urine. In this entire pathway, the points to be remembered is the rate-limiting enzyme is going to be tyrosine hydroxylase, and when they are in excess, the dopamine particularly, how we are going to catabolize with the help of homovanillic acid. Why it is important? Because in the Parkinson patient, the dopamine is less, and we want to increase the dopamine. And because we want to increase the dopamine, so what we are going to do is, we know that these 2 enzymes are the ones that destroys the dopamine. So we are going to block these enzymes. The COMT inhibitor that we have is the tolcapone, entacapone that can be used, and the MAO-B inhibitors such as selegiline, that is selegiline, rasagiline, that is the MAO-B inhibitor. If you use these enzyme inhibitors, the dopamines are going to increase, and that will help in improving the patient of Parkinson. So these are the 3 special products that we have. Now let's have one more clinical correlation here, that is with the name of pheochromocytoma. See how the pheochromocytoma occurs is, normally the tyrosine converts into norepinephrine in the chromaffin cells. By any chance, if there is a tumor of the chromaffin cells, that is called as chromaphinoma, that is also called as pheochromocytoma. 90% of the time, these chromaffin cells are found in the adrenal medulla, and they may generate a tumor in the adrenal medulla. Actually, chromaffin cells are found in 2 places in our body. One is the adrenal medulla, and secondly, they are found in the sympathetic ganglia. So the tumor can originate any of these places, but 90% of the time, the pheochromocytoma originates in the adrenal medulla. Now, this tumor is going to generate a lot of norepinephrine and epinephrine, because there is increase in the number of chromaffin cells. If the chromaffin cells are more, there is more norepinephrine, epinephrine. And norepinephrine, epinephrine, we know that these are the noradrenaline, adrenaline, which is running the sympathetic system. So this patient is going to have excessive sympathetic drive. And because of that, there is going to be increase in the blood pressure, increase in the heart rate, and there will be profuse sweating. And because of the increase in the blood pressure, the patient will have the headache. And this is the classical triad of symptom the patient is going to have. But the good thing is, these symptoms are going to be episodic. They are not going to be permanent, because the norepinephrine and epinephrine, they are going to be broken down very rapidly. So the moment the tumor will secrete these molecules, the symptoms will appear for a few minutes, and then they will disappear automatically, because these molecules will be destroyed. The norepinephrine will convert into normetanephrine, epinephrine will convert into metanephrine, and they will be thrown out. So there is going to be increase in the normetanephrine, metanephrine in the blood, and then ultimately they are going to come in the urine. That is why in the test we use, for the screening, we use the urine metanephrine levels, and for the investigation of choice, we use the plasma fractionated metanephrine levels. So when you will discuss the pheochromocytoma in the medicine, here there they will discuss about these tests, the metanephrine test. So from where it is coming, actually the norepinephrine, epinephrine, when they catabolize, they convert into these molecules. Now coming to the last thing, that is the tyrosine catabolism pathway. See, when it comes to the tyrosine catabolism pathway, we know that tyrosine is required to make 3 special molecules: melanin, thyroid hormone, and catecholamine. If all the 3 are there in the adequate amount, what to do next? The tyrosine will be catabolized, and the tyrosine catabolism pathway, this is how it is going to look like. Ultimately, the tyrosine will be broken down, and it is going to generate the fumarate and acetoacetate. By any chance, if this pathway is not working, the tyrosine will not be catabolized, and ultimately the tyrosine can accumulate, which is called as tyrosinemia. For example, if this enzyme is not there, FAA hydroxylase, then the tyrosine, ultimately the tyrosine is going to accumulate in the body, and that is called as tyrosinemia type 1. If there is deficiency of tyrosine transaminase and ultimately tyrosine accumulates, that is called as tyrosinemia type 2. If there is deficiency of 4-HPP deoxynase and tyrosine accumulates, that is called as tyrosinemia type 3. So we should know that tyrosinemia type 1, 2, and 3, they are due to deficiency of what? And it is very easy to remember actually. See how we are going to remember. Type 1, or I can say type first, the enzyme will start with the letter F. Type 2, it is tyrosine transaminase, so you can remember T2, tyrosine transaminase T2. Type 3, it is the highest the number in the tyrosinemia 1, 2, 3, highest the number, longest the enzyme, 4-hydroxyphenyl pyruvate deoxynase. So type first starts with the letter F. type 2 is T2, and type 3 is 4-HPP deoxynase inhibitor. Among these, there is one more important enzyme which converts the HGA into MAA with the help of the enzyme HG oxidase. If this enzyme is not there, the reaction will not happen, and this disease is called as alkaptonuria. And the majority of the question that comes from this tyrosine catabolism pathway, actually it comes from the alkaptonuria. So now we are going to particularly focus on this particular reaction, and we'll try to understand that actually how the alkaptonuria develops and why it is creating the trouble, and how they are going to form the MCQ. When it comes to alkaptonuria, see, normally we know that tyrosine converts into 4-HPP. 4-HPP can convert into HGA, and ultimately it can convert into MAA, malesyl acetoacetate. To convert the HGA into MAA, we require the enzyme HG oxidase. By any chance, if there is a deficiency, this reaction will not happen, and the homogenetic acid is going to increase. In fact, all the upward metabolites, they are going to accumulate. Now, because this HGA is going to accumulate, it is going to trigger an alternate pathway, and this HGA can convert into a molecule called as benzoquinone acetate. This benzoquinone acetate can create the crystals, and these crystals can deposit in the joint cartilage and can create the problem. They can destroy the joint cartilage, and the patient is going to have the joint pain. Plus, this benzoquinone acetate molecules, they can come in the urine, and when the patient is going to urinate, the color will be normal, light yellow, but because these benzoquinone acetate molecules are there, after the exposure to sunlight, the urine will change the color. It will become dark. So this particular disease is going to manifest by two manifestations. One, the patient is going to have the joint pain, and second, there will be darkening of the urine on standing. This disease will not present at birth, because at birth the joint pain is not there. The joint pain will occur at the age of 30-40, because these crystals will deposit in the joint cartilage and they will destroy particularly the vertebrae. They are going to destroy the intervertebral disc. So this patient will present with the back pain in the age of 30s and 40s. The color changing of the urine is not going to be that troublesome, because no one even notice that you go to washroom and you don't wait for 20 minutes just to watch your urine whether it is changing the color or not. We go, we urinate, we flush, and we come back. So the patient might not be aware that what is it happening or not happening. So most of the time they will present with the back pain, and then we will inquire about these things. Then they will say yes, they are having this problem also. This is called as alkaptonuria. To treat this disease, we use a special molecule called as the nitisinone or NTBC. Nitisinone is the 4-HPP deoxynase inhibitor. It's a partial inhibitor, so the formation of HG oxidase will be relatively less. So we have discussed three special molecules of the tyrosine, that is melanin, thyroxine, and catecholamines. And then we have discussed that if the tyrosine is excess, how we are going to catabolize.